Hello and welcome. Today we're diving into a condition affecting the urinary system, urethral hypermobility. We'll explore what it is, why it happens, and how it's managed. So, let's get started. Urethral hypermobility primarily arises from weakening of the pelvic floor muscles and supporting ligaments. Several factors can contribute to this weakening. Childbirth, especially multiple vaginal deliveries or prolonged labor, can stretch and damage these tissues. Aging is also a significant factor, as hormonal changes associated with menopause lead to decreased collagen and elasticity in the supporting structures. Other causes include chronic cuffing, obesity, and activities that put repeated strain on the pelvic region, such as heavy lifting or high-impact exercise. Pelvic surgery or trauma can also, in some cases, lead to urethral hypermobility. Now, let's understand the mechanics of what happens. The urethra, the tube that carries urine from the bladder, is normally anchored in place by the pelvic floor muscles and ligaments. When these supports weaken, the urethra becomes abnormally mobile. During activities that increase intra-abdominal pressure, like coughing, sneezing, or straining, the urethra can rotate and descend downwards. This descent disrupts the normal pressure gradients required for continence, making it difficult to maintain a closed urethra. The angle between the urethra and the bladder neck widens, compromising the urethral closure mechanism. This leads to leakage of urine, which we know as stress urinary incontinence. Urethral hypermobility is a fairly common condition, especially in women. Its prevalence increases with age and the number of vaginal deliveries a woman has experienced. While accurate statistics are difficult to obtain because many women may not seek medical attention for their symptoms, studies suggest that it's a contributing factor in a significant percentage of women experiencing stress urinary incontinence. The incidence is lower in men, primarily because of anatomical differences in their pelvic floor structures. However, urethral hypermobility can occur in men following radical prostatectomy or other pelvic surgeries. The hallmark symptom of urethral hypermobility is stress urinary incontinence. This means urine leakage occurs during activities that increase abdominal pressure, such as coughing, sneezing, laughing, exercising, or even just standing up. The amount of leakage can vary from a few drops to a significant gush, depending on the severity of the hypermobility and the activity performed. Some individuals may also experience a feeling of pelvic pressure or bulging. It's important to note that stress urinary incontinence can also be caused by other conditions, such as intrinsic urethral sphincter deficiency, so a thorough evaluation is necessary to determine the underlying cause. Diagnosing urethral hypermobility typically involves a combination of a detailed medical history and physical examination and specific diagnostic tests. During the history, your doctor will ask about your symptoms, including the frequency, severity, and triggers of your incontinence. The physical exam will include an assessment of your pelvic floor muscles and vaginal support. The Q-tip test is a common test used to assess urethral mobility. This involves inserting a sterile, lubricated cotton swab into the urethra and measuring the angle of movement when you strain. An angle greater than 30 degrees suggests hypermobility. Aerodynamic testing, which measures bladder and urethral function, is often performed to confirm the diagnosis and rule out other causes of incontinence. Imaging studies, such as ultrasound or cystoscopy, may also be used to visualize the bladder and urethra during straining. While there aren't distinct classifications of urethral hypermobility persists, its severity can be graded based on the degree of urethral descent observed during clinical examination and diagnostic testing. This helps guide treatment decisions, with milder cases often responding well to conservative measures, while more severe cases may require surgical intervention. Treatment for urethral hypermobility ranges from conservative options to surgical procedures. Conservative approaches include pelvic floor muscle exercises, also known as Kegel exercises, which help strengthen the supporting muscles. Biofeedback can be used to help you learn how to perform Kegel exercises correctly. Weight loss, if applicable, can reduce strain on the pelvic floor. Vaginal pessaries, which are devices inserted into the vagina to provide support, can also be helpful. Surgical options are considered when conservative measures fail. Sling procedures are the most common surgical approach. These involve placing a synthetic or biological mesh sling under the urethra to provide support and prevent excessive movement. Another surgical option is colposuspension, which involves suspending the bladder, neck, and urethra to the pelvic bone. The choice of treatment depends on the severity of the hypermobility, your overall health, and your personal preferences. Medication typically has little to no role in the management of pure urethral hypermobility. While it may not always be possible to completely prevent urethral hypermobility, there are steps you can take to reduce your risk. Practicing regular pelvic floor muscle exercises can help maintain the strength of your supporting muscles. Maintaining a healthy weight can reduce strain on the pelvic floor. Avoiding activities that put excessive strain on the pelvic region, such as heavy lifting, can also be helpful. If you are pregnant, consider discussing pelvic floor exercises with your healthcare provider. Proper management of chronic cough or constipation can also reduce the risk of developing urethral hypermobility. The prognosis for women with urethral hypermobility is generally good, especially with appropriate treatment. Many women experience significant improvement in their symptoms with conservative measures or surgery. Recent research has focused on improving the durability and safety of surgical procedures, as well as developing less invasive treatment options. Newer mesh materials and surgical techniques aim to minimize complications and improve long-term outcomes. Additionally, ongoing research is exploring the role of regenerative medicine in strengthening pelvic floor tissues. It is important to follow up with your physician if your symptoms persist or recur.